Okay, let's get directly into the emergency area. Get that one on here. We get some more people. Okay, bring up the other stretcher. There.
Okay, we have an evisceration.
Okay, how about vitals?
Vital signs 80/50.
Okay.
Timing of 140, respiration 30.
We're directly to surgery. Let's go with it. Okay, we got somebody there. What do we got, guys?
Okay, help here.
Okay,
Help
we got
here.
that. One arrow here. Yes, let's go directly to the minor area. Okay, we need some help over in the other ambulance. Let's get somebody else out here. What do we got, guys?
Okay, multiple fractures of cervical spine. We got a forehead separation.
This hospital is in the midst of handling a major external disaster. Victims are being cared for in the best possible manner.
We got degree burns going down, burns to the respiratory area.
To be sure, there's a strain on the hospital's capabilities and stress on the staff.
I need a wheelchair.
We need one more wheelchair out here.
But the situation is under control, and lives are being saved.
Burns, a bit of a hysteria.
This is possible because this hospital and other area hospitals have been active participants in a regional disaster plan and have developed and rehearsed their own disaster plans for the hospital's management of mass casualties from an external disaster. These identify the components of planning for external disasters and coordinate them to preserve life. A disaster is any occurrence that threatens or causes loss of life and property and exceeds the routine capabilities of local governmental, community, and healthcare agencies. For the hospital, as well as for other agencies, this excess may be defined in terms of degree. For a small community hospital, a few victims of a severe automobile crash may exceed its normal capability. For a large hospital, an influx of 20 victims of an explosion or fire may not put a severe strain on its physical and personnel capabilities.
Well, let's go to emergency.
But 50 or more victims may well require special, pre-planned measures for providing facilities and personnel to save lives.
Okay, what do we got, guys?
Okay, we got
To manage mass casualty situations, the hospital must develop a detailed plan for coping with disasters of various magnitudes and must coordinate this plan with other hospital and regional disaster
Need
plans.
some more help back here.
Emergency, Miss Marty speaking.
Essential components of hospital disaster plans are notification and verification that a disaster has occurred,
Explosion and advanced chemical.
activation of the disaster plan,
Refer to your manual and make...
personnel deployment, allocation of physical resources,
Second and third degree burns here.
triage, security and traffic control,
8
communications,
beds available.
It's gonna be all.
and special situations.
I'm scared. I don't even know what's going on here.
Advanced Chemical Company, 8930 Southwest 90 Street.
With a regional disaster plan, disaster notification usually is more organized, so that most often a fire or law enforcement department is responsible for informing a receiving hospital or hospitals of the type and number of casualties involved.
Fractures and 4 abdominal injuries.
Baptist, may I
The
help you?
disaster plan should designate who should receive the notification, usually the emergency department. However, if the call comes through the hospital switchboard, the operator should route the call to the designated phone.
To the emergency department.
Sometimes notification of a disaster will come from the press
The Associated Press.
or from an individual at large. In such a case, the plan should specify a procedure for verifying with an official agency, often the fire department, that a disaster has
We
occurred.
got that information about 5 minutes ago. You haven't received anyone, no information at all.
The person receiving the notification should determine type of disaster and location, estimated casualties and type if known, estimated time of arrival of casualties, mode of arrival, name and position of caller, need for hospital's disaster team at the site. Then, the person receiving the notification must inform appropriate members of the hospital staff according to the plan. These include the administrator on duty, disaster committee chairman, the chief of staff, the emergency department director, the senior nurse on duty. The plan should call for these persons to meet in a designated control center or command post, often in the office of the administrator or the emergency department director.
All we know now is there are 150 people in the chemical plant at this time. We don't know the number of casualties.
I think we'd better go up to the control center.
Yes.
The decision to activate the disaster plan is made in the control center by the senior administrative and medical staff persons physically present, usually the administrator on duty and the emergency physician. The control center personnel also determine the level of response. This level will be defined by each hospital's plan and be determined by the number of casualties, the type of injury, and the estimated time of arrival.
21 on the way. There are burns.
It will determine the magnitude of the response of hospital facilities and personnel. 1 to 5 casualties, for example, may be managed as standard operating procedure, or level 1. 6 to 15 casualties may require a level 2 response, with partial call-up of personnel and a defined partial response by the emergency, surgical, and other departments. More than 15 casualties may necessitate a level 3 response, calling for all the hospital's resources.
Utilize a medical team out to the...
This is the case here, to deal with an expected 50-plus casualties.
We anticipate just a flood of calls.
At this point, when a disaster plan is put into effect, additional control center personnel are brought into action. Public relations, to handle news media and family relations, and administrative clerical personnel, to maintain communications with other hospital departments and external agencies.
We've got the other conference room in the back hallway set up for the families.
Once the disaster plan is activated, the most critical aspects are deployment of personnel and physical facilities. The senior nurse on duty should assume responsibility for the gathering of nursing power needed to manage disaster victims. The control center needs to conduct a census of personnel and facilities, both existing and short-term. It must determine, usually through a departmental call-up by the admitting office, the number of beds available, especially in the critical care unit, and those that can be made available by canceling elective admissions, as well as a count of personnel immediately available and those available on call-up.
She's had no symptoms, no nausea.
Additional beds may be made available by discharging patients through a discharge center staffed by physicians, nurses, and social workers. If the response level indicates the need to do so, elective admissions and elective surgery are canceled.
Why don't you take her back to her room, because I think this will be much...
Other physical facility needs the control center must assess include medical supplies. Each area responsible for these should report to the command center its capabilities, both immediate and short-term. Personnel must be similarly inventoried. It's essential that the control center have an accurate inventory of physicians, nurses, X-ray personnel, and laboratory personnel available on an immediate basis and on call. Plans should provide for supervision of volunteer personnel. If additional personnel are needed for management of anticipated casualties, each department should begin its call-up as directed by the control center and disaster plan. Personnel resources, as well as proximity to the disaster site and the specifics of hospital and regional disaster plans, will be factors in whether or not to send a disaster team to the site. If it's needed and requested, the control center may send a team consisting of an emergency physician or senior resident, plus 1 or more nurses. Proper allocation of personnel and physical facilities will to a large extent be determined by the triage. The triage area should be located as close as possible to the point at which victims will be arriving at the hospital, immediately outside or inside the emergency department entrance. It should be staffed by a physician, nurse, respiratory therapist, transport persons, and admitting persons. If disaster site triage by EMTs or paramedics in the field and by a physician transportation officer at the transportation site has been effective, triage at the hospital will be simplified. Ideally, with effective site triage, the first patients to arrive will be those who will benefit most by immediate hospital care, not the dead or moribund, or those with minor injuries whose treatment can be delayed without serious health consequences. But don't depend on it.
Just move an arrow, okay, on both sides.
A commonly used site triage method is to use red tags for victims whose lives may be saved by immediate life-saving measures. If triaged accurately at the site, these patients may already be on non-surgical treatment. Yellow, or urgent tags, are used for victims with extensive skin wounds, obvious fractures, or moderate burns. These victims are the ones who can benefit most from prompt transportation to and treatment in the hospital. Green tags, minor injuries, and black tags, dead or terminal, may arrive with or soon after other victims, although they shouldn't if on-site triaging is effective. These victims should not be given first priority attention.
Got second and third degree burns.
The hospital's triage officer's responsibility is to do a hospital-level triage and assign victims to the appropriate area for treatment.
Call surgeon, tell him we're on the way.
The severely injured, the Reds, are sent to a central resuscitation area, usually in the emergency department. Those requiring surgery may go directly to the operating suite. For those victims who are dead on arrival, a temporary morgue must be set up in an area designated by the disaster plan. Victims with minor injuries can be treated in outpatient areas or in areas such as conference rooms where patients are not ordinarily seen.
Here, anybody's gonna help us? We need some help. We've been here for a long time.
Hysterical victims may upset the best plans by calling attention to themselves and drawing resources away from others.
I'm not fine. Never mind, I'm fine. I'm not fine. I want to go home now. Anybody's gonna help you now.
To maintain order and to permit the greatest freedom of movement possible for hospital and disaster response personnel, hospital security, supplemented as necessary by law enforcement agencies, should implement traffic and crowd control measures.
Attention, all departments, code 7. All visitors, please leave the hospital.
The control center should initiate public address system announcements, asking visitors to leave the hospital once the disaster plan is activated.
I'm afraid you'll have to cut your visit with your mom short.
Crucial areas of the hospital should be blocked off to all but authorized personnel.
We got to get down to emergency.
Is some of your family in there?
Yeah.
Well, we have a family emergency center set up, which is down the corridor.
A system for identification of hospital staff involved in a disaster management situation may be established. Traffic management to maintain access to the hospitals by emergency vehicles is an important function of security during a disaster.
You're busy.
Communications during a disaster response have several aspects that should be covered in the hospital's disaster plan.
All security personnel to the emergency.
Notified the Coast Guard to fly in some helicopters.
We have not been able yet to notify their families. As soon as we do...
We are declaring this a disaster today.
Communications within the hospital usually are designated as the responsibility of the switchboard under the direction of the control center.
All departments, code 7.
Upon instructions from the control center, the disaster alert is to be issued.
Departments, code 7.
The signal for each department and staff function to begin execution of its responsibilities under the disaster plan.
Cases in progress. And,
These include inventorying physical and personnel facilities, departmental call-ups, and communication of required information to the command center.
the cases are finished. I'll need to know that.
The switchboard or communications center also is responsible for screening and proper routing of incoming calls.
We have an emergency. Please call back later.
Non-disaster related or non-emergency callers should be told the hospital is on an emergency alert and that they should call back when the emergency is over. Calls from the press or from relatives of victims should be directed to the press room specified in the plan or as directed by the command center and to the area specified for relatives.
We need a current status in the emergency department, please.
To minimize internal communications clutter, voice pages should be limited to disaster-related items. Some of the clutter can be avoided by providing key personnel, including the disaster coordinator, the administrator, the nursing director, the chief of staff, and possibly others, with two-way radios or walkie-talkies. Most hospitals also have one-way radio pagers or beepers that can be used for alerting key personnel.
We can handle no more than 2 more critical. 4
Another
serious,
important facet of communications is that between the hospital and the disaster site.
And then we'll update.
This is Tom Moore.
To send data about the hospital's capabilities of managing victims and to receive information about casualties.
Victims from the disaster site.
This almost always must be done by radio, either directly to the site commander or his designated communications officer,
Compound fracture.
3 severe burns.
or through an emergency operating center, or EOC, if one is established. Communications with the press, and often with relatives of the disaster victims, are the responsibility of public relations. All press calls and reporters from print and electronic media should be directed to a designated press area under the supervision of the public relations staff.
Keep you informed and updated as we get the information.
All I'm asking for is
Public relations and the disaster coordinator should determine whether or when the press can be admitted to triage and treatment areas without compromising the management and health of the victims.
Film outside the emergency department. There's an area there. Just stay away from the rescue vehicles.
An area also should be designated for relatives of victims. Communications with relatives are usually coordinated by public relations, often with patient representatives, social service, and the chaplaincy to help deal with relatives and friends of victims. An important aspect of communications or information systems is that of patient records. Admitting department personnel begin record keeping in the triage area. Sometimes, as here, admitting charts the site disaster tag number along with as much identification as possible under the circumstances. Often, a 3-copy tag is used. 1 copy for the control center, 1 for admitting, 1 to remain with the patient until the standard medical record is prepared. The tag is attached to the patient's body, not to the clothing. The triage officer may indicate that a previous hospital record, if any, for the victim should be sent as quickly as possible to the area in which the patient is being treated. It may provide information important in treating the victim and will facilitate further record keeping. Special situations and problems also should be anticipated and planned for. Examples include victims of disasters involving radioactivity, who must be decontaminated away from patient care areas and checked by a health physicist before they are admitted to the emergency department. Victims exposed to hazardous chemicals and victims of civil disorders also may require special plans and procedures. The weather or a natural disaster such as an earthquake may result in additional problems. Traffic, inability of the staff to get to or leave the hospital, and disruption of public utilities and communication systems both inside the hospital and with outside agencies. A key point in the genesis of a hospital's plan for external disasters is the disaster drill, as required twice a year by the Joint Commission on Accreditation of Hospitals. All components should be rehearsed. Notification and verification that a disaster has occurred. Activation of the disaster plan. Personnel deployment. Allocation of physical resources. Triage. Security and traffic control. Communications. And special situations.
It's probably appropriate that we take a minute and critique what's happened while it's still fresh on our minds.
Post-disaster critiques and critiques of disaster drills are an essential part of the hospital's disaster planning. Because of staff turnover and the rarity with which disasters occur, the disaster drill is essential in training staff to perform under even the most difficult situations to preserve life, and is invaluable in evaluating the plan and improving it.